due to medication errors and unsafe practices, and advocating urgent action to improve medication safety. Therefore, the College of Pharmacy, in collaboration with the Ministry of Public Health and the QU Health CPD department, has organized this event and invited experts in medication safety who will be discussing strategies to enhance medication safety and address your concerns. So I would like again to thank our panelists for accepting to be part of this event and to share their experience. So please join me in welcoming our panelists. So we have Prof. Derek, the Professor of Clinical Pharmacy at the College of Pharmacy, Qatar University. We have Dr. Anas Hamad, the Director of Pharmacy Department at the National Center for Cancer Care and Research, and he is the Head of Medication Safety and Quality Center at Hamad Medical Corporation. And we have Mr. Thabit Melhem. He is the Executive Director of Nursing, the Corporate Nursing and Midwifery. And we have also Mr. Amr Iqbal, who is the Medication Safety Officer at Tidra Medicine. So welcome all, and thank you so much for having me. After that view, so Dr. Zach, would you like to introduce the outline? Okay, sure.
So for today's event, we're very much looking forward to the interaction from our audience, both our online audience and face-to-face audience. So you can see here the structure of today's event. There'll be 10-minute presentations from our 4 panelists. And following these 4 presentations, there'll be a panel discussion between the experts, and we'll also be taking questions from yourself, from the audience. We've collated your questions that you sent it to us earlier today, and we'll also be presenting those to the audience as well. So just to give you a brief background of the learning objectives for today's event, we wanted to discuss the burden of medication-related harm due to medication errors and unsafe practices, to identify effective strategies to prevent medication errors and reduce medication-related harm, and finally to analyze strategies to empower patients and families to be actively involved in the safe use of medication. And our first speaker today is Dr. Anas Hamad. So I can welcome you to the stage, Dr. Anas.
Thank you, Dr. Zakaria. Thanks for your help for arranging this education multidisciplinary activity. It's a great pleasure to be here with esteemed colleagues from different healthcare providers and health education facilities in Qatar. So I have just 10 minutes, so just go quickly about medication errors. What's medication? How important is that? What's the burden of that on us as healthcare providers and also in the community and public in general? So this is Qatar Patient Safety Week. It's not only about medications, but this year's medication without harm is the theme. So healthcare, of course, is a basic field. It helps cure diseases and relieve suffering. Many of the diseases that maybe our parents or grandparents were or their friends and families were dying from are now easily treatable with just a couple of pills. We can say many examples of that. However, on the other hand, unfortunately, healthcare, despite all these developments, is still a big source of patient distress and harm. This was published in 2016, and it shows in the BMJ, and it shows that medical errors are the third, or can be counted. It's not, of course, an official number, but based on this research and the extrapolation, is the third leading cause of death in the US, and that's after cardiovascular disease and cancer. So it's a big problem, it's not a small problem. And this is all medical errors, not only medication errors. Just some diving back in history, so there were mixed opinions about medicine early times in early Greece and that. So the double idea of death and doctor riding together was always there. In ancient Greece, Apollo was the god of physics and the center of diseases at the same time. The word pharmakos meant both remedy and poison, and the words kill and cure were nearly indistinguishable. Hippocrates, the legendary Greek physician, has the very famous dictum that says, first, do no harm. In modern medicine context, Florence Nightingale, the founder of nursing, modern nursing, she introduced her book. It's called Notes on Hospitals. That was in 1863, so 160 years ago. The first, actually, the back of the cover of the book itself have this statement. It may seem a strange principle to enunciate as the very first requirement in a hospital that it should do the sick no harm. So this issue is way long and well established. However, still we cannot completely resolve it. Why is that? Despite all these technologies, despite all these development, because it's a very complex issue and has so many factors contributing to it. Focusing on medications now, our topic of today. So medication safety has so many definitions, but like the simplest one and in the same time comprehensive one is from ICMP Canada, which says medication safety is freedom from preventable harm with medication use. So of course it's always preventable. There is the non-preventable. Somehow we cannot do anything about it, but the preventable one is our main focus. Medication safety, of course, can impact health outcomes, length of stay, readmission, and overall costs as well. So we're focusing on medications because they are the most common used intervention in healthcare. Around 90 to 95% of patients going into the hospital will take at least one medication through their stay. Medication errors are very common, unfortunately. In all different, any place you do a study about medications, you will find that they are common. And the harm because of errors also is common. It's always one of the top three in any patient safety incident analysis. Medication optimization can keep people out of hospital, reduce readmissions, and save costs as well, lots of costs. This was published in the Telegraph. It says that millions of GP prescriptions in the UK contain dangerous errors. I'm giving some examples from the UK because this is where I studied, not because it's a good example actually, because there's good capturing. It's not a bad example. So 2 million GP prescriptions contain potentially life-threatening errors in those given in 1 in 5 patients. So 20% of prescriptions written by GPs are potentially dangerous or life-threatening. And the main reason for that is not lack of understanding, as you can see below, or knowledge. It's actually human error. We can all make humans. We are errors. We are humans, and by nature, humans make errors. So what can systems do about that? In terms of cost, in the US, this was published in 2010, and it shows that preventing medication errors is a $21 billion opportunity. The WHO later has also estimated that global cost of medication errors is $42 billion. Of course, this is what we know. What we don't know is even more. This is called the medication error iceberg. One of my PhD supervisors actually co-designed this. And the idea is that what we know is very, very minimal. And all retrospective, studies, active studies, have shown that what gets reported is like 5% to 10% of what is really happening, or sometimes less. So what we know is usually the errors that cause big problems, cause harm, nobody can hide anymore, or they are the ones that could really lead to very significant harm. Some errors which are considered indistinguishable or sometimes unnoticed, go unreported, although we can learn a lot from them. Where do medication errors happen? Any stage in the medication use process, all the way from procurement, storage, prescribing, dispensing, administration, and monitoring. Any stage of those can have medication errors happening in it. Of course, the distribution is different based on the studies, but this is a landmark study that was done by Lucian Lee. Some people consider him the godfather of patient safety, and he's a physician by background. I think he's still alive. Out of every 100 inpatient medication errors, half of them happens in the prescribing stage, quarter of them in the administration, and the rest in dispensing and transcribing. Transcribing is reducing now because of the electronic prescribing. It's reducing the transcribing issue. Why do medication errors happen? Of course, this needs a full lecture by itself, but in general, we have what is called latent conditions. So the conditions that are outside our control, financial, economical, political, etc. These are leading to contributory factors. Contributory factors can be in the work environment, team factors, individual factors, task factors, and patient factors. And these contributory factors will lead to unsafe acts, either mainly by errors and sometimes by violations. And we don't look about criminal violations here. We mean like you feel that this is, I am, in rush, I will just skip this, like workarounds, etc. These unsafe acts, if there is no good defense and barrier layers, they will lead to, unfortunately, to accidents or to patient errors reaching to the patient. So these defense layers are like the Swiss cheese, the James Reason Swiss cheese, and Sishia here have adapted this to medication errors. And they say that, and adverse events generally. And these can be like education, training, policies, technology, communication, checklists. These are the defense layers that we should have to avoid adverse drug events. But sometimes, unfortunately, there's gaps or holes in these cheese layers, like new employee, new equipment, new writing brand instead of generic, etc. Family, language barrier, etc. So these holes are the ones that should be filled, and so the errors that will still happen, we will always make errors as humans, will stop the errors from reaching the patient. This is the most important part. So harm will not happen. Again, how frequent are medication errors? Again, many studies about that. One landmark study was done by colleagues in Manchester. It's called the EQUIP study. It's a big study in 20 NHS hospitals that showed that 9% of orders written by junior doctors, and by the way, junior doctors make more than 50% of prescribing in any healthcare system, 9% contain at least one medication. Range, of course, from 7 to 15%, and these are affecting up to 50% of hospital stays. So 50% of patients going into the hospital during their stay, 10 days, 20 days, 5 days, 50% will have some medication errors happening with them, unfortunately. Of course, many of these are insignificant, but there's still errors happening. Yeah, I'll skip this one. It's just that we have to focus on harm. So just the last two slides about harm. So most of the errors, thankfully, do not cause harm. That's great. However, with the huge numbers that we have, still the harm is not in number is significant. Some people say less than 1%. Some other studies have more. David Bates, again, one guru of medication errors, have a study that says each preventable adverse drug event increased the length of stay in the hospital by 4.6 days. If you count this into how many errors we have, this will lead to so many number of days. In the UK, they say avoidable adverse drug events lead to 180,000 additional good days. This slide is newly published about systematic review. It's just included 81 studies from 285,000 patients. They just showed that 3% of medication preventable orders, of those patients have preventable medication harm. 3% preventable medication harms. Mainly, we're seeing in elderly patient settings or highly specialized or surgical care and emergency medicine. Preventable medication harm, the mild one was around 40%, preventable 40%, and life-threatening or severe around 25%. That's very significant. Of course, the areas that were mostly involved in this were either central nervous system and cardiovascular medicines. This is my last slide. It's a like infographic from the Pharmaceutical Journal about a study that was done in the UK, and it shows that in the UK, the total number of medication errors happening in 1 year, by the way, the UK population is 68 million, is 237 million errors. Of course, it's an extrapolation study, but it was widely published in the UK and promoted. 712 direct cause of death, £100 million cost. As you can see, although administration is the most one, but prescribing, which is the Navy one up there, prescribing has the highest number of severe errors, around 1 million and 50 million, so 2%. The most errors are happening in primary care, again. There's lots of details, we can share the slides, but the idea is that it doesn't mean that the UK healthcare system, for example, is not good. It's actually, they have a good system for reporting and capturing and analyzing. All of us, we know that we have errors. Even here we have errors. Everywhere have errors. But the thing is how to analyze these errors and try to learn from them to do proper actions and strategies to reduce the harm, which our next speaker, actually, Prof. Derek, will focus on. Thank you very much.
So we will actually continue on with our panelists, and then we will take on the questions and the discussion. So, Prof. Derek, please join us.
Okay, ladies and gentlemen. Ladies and gentlemen, we'll now continue with our second speaker, Professor Derek Stewart.
Okay, well, thank you again to the organisers for inviting me to speak at this wonderful event to really raise awareness of aspects of medication safety. And I've been working and researching this area for decades, including research that we've conducted here. So it's really just to give you some insight, not into specific strategies, but I'm going to try and show you and convince you that there are so many strategies for improving medication safety that sometimes you don't know where to start with them, and they're just really a bit overwhelming. And back in 2017, Liam Donaldson, who at that time he was the Chief Medical Officer in the UK, led a piece of work from the World Health Organization. And this was really important. It's called the Third Global Patient Safety Challenge. So it was the third safety challenge released by the WHO. And it focused on medication. It was called Medication Without Harm. And within that document, it mandated every country in the world that within the next 5 years, they would reduce severe preventable harm from medication by 50%. That's a hugely challenging statement to make. And if you count with me from 2017, 18, 19, 20, 21, 5 years from 2017 is now. So it'll be interesting when the countries have to report back to the WHO their progress in meeting that target, how far we've gone. But it's important in that document, it's speaking about preventable harm, because not all harm is preventable. Healthcare is extremely risky. A lot of things that we do in healthcare have all got risk with them. Every medication that you swallow, raw, inhale, inject has got a risk with it. Every nursing procedure, every surgical procedure. So here we're speaking about the preventable harm. And when we look at the evidence around what to do to prevent that harm, it really is overwhelming. There is so much evidence out there. It's maybe not all high quality, but there's a raft of high quality evidence out there. So where do we start with all of that? And within that Medication Without Harm document, it actually gives us many, many, many things to do. And you can see they're centered all around the patient and healthcare practice. There are actions for healthcare professionals, actions around specific medicines. Dr. Anna says that's our biggest therapeutic approach in anything to do with healthcare. So we really do need to focus on medicines. If you look at the big explosion in the number of medicines that we've had over even the last few years, about 10 years ago, I used to teach therapeutics of diabetes. And at that time, we had 3 or 4 different medicines for diabetes. Now we've got 30 to 40, 50 medicines for diabetes. And that's just one condition. So we need to focus on the medicines. We need to focus on the systems, the practices of using those medications, and then to look at the patients, the public. So within each of those 4 things on the outer layer of that circle, there are then lots of approaches as you come inside the circle. So we know lots and lots of ways to help to prevent that harm. But how do we manage all of that? And if we look at the hierarchy of evidence on the left-hand side in this slide, we've got evidence that comes from expert opinion, all the way up to the very strongest of evidence from systematic views and meta-analysis. So we've got lots and lots of evidence there. We've also got the qualitative research evidence of how people feel about things, the real depth of research that really lets us understand behaviour and influences on behaviour. So putting all of that together, it should be easy. As I say, it's overwhelming. I'm the editor of a pharmacy journal. I'm lucky I've got Dr. Zach and Dr. Anas on the editorial board. We receive 1,200 submissions per year. About half of those will be relating to medication safety and medication errors. And most of those studies, we know the answers before we read the studies. So as I say, we've got lots and lots of evidence out there. But there's a big, big difference between having the evidence and translating that evidence into education and practice. And if we were translating it well, I would not keep receiving the same studies again and again, again. So there's a big gap between moving from research or documents telling us how we could do something to actually doing it. How do we really translate it into education and into practice? And that's the real difficulty. It's estimated that it takes about 20 years for 5% of evidence from high quality studies to ever get into practice. So all this work we're doing on research doesn't actually get anywhere. So we've got this plethora of evidence. You know, how anybody can keep up to date with all the evidence, I don't know. We don't know that all the evidence is high quality. The biggest thing is, can we actually implement it into routine practice? And is there sufficient focus on all aspects of an organization, from the layer that's of decision-making and leadership, through the systems that we work in, down to the individuals? And I'm sure you've all worked in organizations where policy direction comes out and you think, I don't think they've got any idea of what we actually do at grassroots level. How can we possibly implement this policy? And then you'll have people at the practitioners at grassroots level thinking, I know how we could improve this, but we can't get it into policy. So quite often, even when we try to translate the evidence, there's no coherence in the system, that everybody's speaking with the same voice, trying to do the same thing. So there's a big disconnect between all the strategies that are in that WHO document, all the research evidence that we've got, and how we actually get it translated into practice and into education. If we can get it into education, then our next raft of practitioners that graduate and qualify will practice in that way. So it's really difficult. And one of the reasons, when you look at healthcare, it's a really challenging environment. Anybody who works in that or has worked in that will know. And it's often linked to aviation in terms of risk. And if you look at any busy hospital ward, you've got very ill patients who can't communicate very well. You've got many different health professionals that you probably don't truly understand what everyone does. You've got lots of new innovations coming out, new technologies, new drugs, new systems of working, and then the staff change over very, very frequently. So healthcare is really dynamic and really risky. So if you're trying to change something from the evidence that we've got, it's actually really difficult to do. And we've got to think in terms of all this evidence and the strategies, what's the goal? Because not all errors are preventable. So we need to think, what are the serious errors and how do we really prevent them? And every healthcare system has got an approach for reporting errors. We did some research in Hamad a few years ago, which really shows the same as everywhere else in the world. There's vast underreporting of errors. And when we started to look at the reasons for that, emotions was a major factor. People were frightened to report errors. They were frightened of the consequences of reporting them. They felt, when I've reported in the past, it made no difference, so I'm not going to do it again. So if the reporting systems don't work, we can't learn from these errors. We've seen it already with the Swiss cheese model. Things will always go wrong, but hopefully if you've got layers of defense. The reason it's called the Swiss cheese model, if you look at Swiss cheese, it's got holes in it. So what should happen if an error happens one part of the system, it will get through a hole and then it'll get blocked because something else in the system is going to pick it up. So if a doctor makes a prescribing error, maybe the pharmacist will pick it up. But if it gets through that hole, maybe the nurse will pick it up. If it gets through that hole, maybe the patient will pick it up. And if it gets through that hole, you've got an actual error. And what we're trying to do is strengthen each of those layers because things will go wrong. Okay, so we need to look at things like minimizing the errors, minimizing harm. And I really like this slide, not because I put it together, but I extracted it from other places. And it actually looks at how we go from something new to sustainability, and that's what we need. So we're good at innovation. All these papers I get submitted about new things. We publish some of them, so we diffuse them, that's very passive. What we're not good at is going to dissemination, which is very active, planned efforts to persuade people to adopt that innovation. We're less good than at implementation, which is mainstreaming it, and we're very poor at sustainability. So something new is no longer new because we just do it all the time. So what we're trying to do is transform so we have transformation. And this is a good model that comes from management of how to do that we create a feeling of urgency. Why do we need to do something? We build the group that we need to carry it out. We form a strategy. We communicate and enlist everyone that we need to be involved. We empower people and enable them. We generate the ideas and the goals from those strategies to then sustain it, and we institute it into practice. So that's what we're trying to do with these innovations. We've got plenty of evidence, but we need to somehow get into practice that's then sustainable. Thank you.
So much, Prof. Derek, for sharing with us some strategies to reduce or prevent medication errors. So I would like to welcome Mr. Constantine to discuss now strategies from a patient and family perspective. Thank you, Mr.
Good afternoon. Assalamu alaikum. My name is Tariq Moham. I'm Executive Director of Nursing, Corporate Nursing and Midwifery in Hamad Medical Corporation. It's a privilege to be here and thank you for the invitation. Thanks to Qatar University, Dr. Zakria, as well as the MOPH and the organizers for this event. So we've seen earlier in the presentation, our colleagues, Dr. Anas, really highlighted the importance of why we needed to kind of pay attention to medication errors and the impact of medication errors. And Prof. Derek did touch on the different strategies really that we to kind of, reduce medication errors, looking at the evidence and how do we use that. I would like to kind of, talk in particular about one area that is very, very important, and it's really about how we transform care. How do we transform the way we care for our patients? But I wanted to kind of, I'm not going to go into a lot of details here, but Dr. Anas really did touch on the cost area, and the same report in 2010 also did talk about that medication error really, supersede the motor accidents and other areas as well. But also there were 98,000 deaths that were reported in the 2010 report, really, that are related to medication. And I wanted to say that medication in the U.S. It's comes wider. My training in the U.S. and I've worked for many years, and I think we had a partnership and strategies and some sort of learnings. I do think that when we talk about these deaths, the community and the structure in the U.S., there is more challenges that we see in North America with the medication use than other countries. So I don't want to kind of highlight that all of these, but an area that is very important when we talk about the reported medication error, we talk about clinical settings usually strive to kind of improve their reporting. So we do see data that comes from the clinical setting, but the challenge really in the community, the challenge is that when you have a patient that goes to a clinic, you find out that there's a drug interaction or there's a problem with that medication. We're probably not seeing a lot of that data. And my colleagues, Dr. Anas, really touched on and proved also that there is a likelihood of the underreporting really of medication errors and events. One of the contributors in that report for medication error is the lack of knowledge about drugs that the patient is taking. And I think I'm really highlighting this particular area because that is a challenge that we're going to take forward into talking about how empowering the patient. So how do we improve medication safety? This is not the only strategy, but I wanted to focus on empowering patients and their family to be involved in managing their medication, help improve medication safety. And I think that is a key because patients are more educated these days. There is access to the internet. Google is many use the internet really. Many of our patients and their family use the internet to find information. And that really provides an opportunity, but also provide a challenge and a risk. So how do we do that? We take it to the next level of when we look at the challenges for the patients, when we wanted patients more to manage their medication, there is a challenge with that. We did touch on the area that there is patients use the internet. There is a challenge with some of those websites. There is a challenge with their reliability. Patients may change their medication regime. They may change a prescription based on what they read on the internet. Patients might start replacing their prescription drug with complementary alternative medicine. We're talking about the over-the-counter expanded. This is becoming a challenge. People are traveling more often, and then from one country to another, the name of the medication is different. That's another challenge. So where do we go from here? We go to really empowering patients. We need to put the patient at the center. We want to have patients to take responsibility for their own medication, and we don't want it to focus on patients, but also focus on family as well. Patient is a key and has a key information, key member of the team. We need to kind of transform as healthcare provider, transform the way we deliver care and view the patient as a partner, not only as a listener, and we are the most expert, but I think as a partner, because the patient comes with the very important information that helps us improve medication safety. And I think that when we treat them as a partner and allow them for opportunity to speak up, there are many issues that can be resolved. And there is an evidence actually, there's many evidences out there about, you're probably not many specific about medication, but you see a lot of evidence about involving patients in their care and patient engagement and impact on adverse events. So we need to instruct the patients always to keep a list of their medication, to bring it to their healthcare provider, and patient family can be an additional layer of defense really. And Prof. Derek did touch on the Swiss cheese model, and the last one is really the patient. So really we wanted to kind of enhance that by partnering with the patient. So we encourage patients to speak up and prompt providers if there's a concern about medication. I think we need to kind of feel comfortable, inform the patient that they are part of the healthcare team. And I think the key is really creating a culture where the patients and family participate in their healthcare. And really we wanted our future healthcare providers really to kind of help us with really having the patient feel comfortable in creating that environment. I think that the Joint Commission, International Joint Commission in the US, Hamad Medical Corporation is accredited by the Joint Commission, and the Joint Commission have a lot of emphasis on a program that's called the Speak Up. And I wanted to highlight this program because this program really kind of illustrates how do we really transform care to have the patients really engaged and speak up. So the goal of the program came out in 2002, and now we reached 70 countries. They did refresh and relaunch the program in 2018. Program really include infographic posters, animated videos, and help for the patient, and it's available, accessible to the public as well. This material help the patients communicate with their healthcare provider better. The program really have information about telehealth, discrimination, anesthesia, sedation, antibiotics, and medication. And I want to highlight a little bit details about the medication piece. But this program is really meant in a way to teach patients to say that, speak up, talk about that. If you feel there is a discrimination, there's a problem, and it provides a lot of details for the patient. And so for the Speak Up program that's specific to the medication, there is some categories, and those categories is that over questions really looking at who's responsible for the medicine, what should you know about medicine, and what if you forget instructions. And I kind of included just a copy, and I apologize. Probably the font here is small, but this particular really give instructions, and it's actually available, and we have the link here as well. So this has a lot of good information that can be shared with the patient to really to help them to kind of ask questions and to their healthcare provider. For example, looking at the label, knowing their medication. What if you don't know? You need to ask your healthcare provider, and really encouraging them to participate and speak up. And I think one key that I personally have learned from one of the events that we have looked at previously, it was not a medication event, but it was a serious event. And we have seen really in particular, and that was in a different career, but that really looking at how patient engagement really and empowering patient really could prevent serious events. The takeaway here, if I wanted to kind of just the one takeaway here from my presentation is really, we need to put the patients at the center, and we need to partner with the patient. Patients come back to us with a lot of valuable information about medication that they take at home that we're not aware that are non-prescription medication. But I don't think this is only the key, but the patient brings a lot of other information about their reaction, what works well, what doesn't work well for them. The patient opinion really is very important, and we really need to encourage that as a healthcare provider and to view the patient as a partner. And this is the conclusion of my presentation. Thank you.
Thank you so much, Mr. Mafhem, for sharing us the strategies from patient and family perspective, which is equally important as other strategies. So I would like to invite Mr. Iqbal to talk about medication safety from a family perspective. Thank you.
Thank you. It's been quite informative, the presentations this afternoon. I just want to say I'm going to focus more on cases. So you'll get more of frontline practice that we see on a day-to-day basis. I work in med safety. For the last 15 years, I've worked in quality, safety and education. So it gives you a different perspective and show you what happens on the front line. So we know medication safety can affect different areas, whether that's selection and procurement, all the way through education and training, so across the medication management stages. We know that from our presentations earlier on. We also know that it can affect across different healthcare sectors. So for example, at local level within a hospital, or at wider level within the healthcare system. So in order to affect change, we need to look at each of these areas, so the medication management stages, and also the system that's around us. And that needs to enable safety. So you might think, why have I put some news from the UK? So this is almost 20 years old. Teenager given wrong drug advice. This was an error in the UK where a junior doctor gave vincristine via the intrathecal route, and it should have been given via the IV route. So they got confused between vincristine and methotrexate, so two drugs that were going to be given on the same day. Another error, again from the UK, baby died after decimal error. This was a cardiac medication, digoxin, where a nurse miscalculated the dose, and there was a 10-fold dosing error. Again, led to a fatality. This next headline is from a prescribing error, where a patient was prescribed for dental pain a fentanyl patch, an opioid naive patient. So they were quite old, but they actually suffered and they died from this particular error. And one that crops up in the literature, you'll notice a few products on the bottom there. You've got sodium chloride, water for injection, potassium chloride. So we know from literature there can be confusion between these products. We tend to segregate these products because we have had situations where patients have received potassium chloride inadvertently, ended up with cardiac arrest and died. But why are these important? These errors are from other countries. The reason why they're important is to prevent harm. In Qatar, for example, we need to look at these errors and we need to actually do something to prevent them from happening in our system. One of the barriers to safety, and it was touched upon in a number of the presentations today, is health literacy. So health literacy bases around personal ability and skills, and also the situation and the circumstance that a patient or a healthcare professional is in. So that's one of the biggest barriers. So getting people to understand medication, why they're taking it, and to make it safer for them can be quite difficult when you've got 89 or 90 different nationalities in the country. Some of the other barriers are around educational and cognitive function, systems and processes. Obviously, if the systems and processes are not right, they can lead to errors. So we need to look at our systems and processes. Cultural and linguistic barriers, and then economical or resource barriers. Some people may not be able to afford the healthcare, so they may have shortcuts, so they may take medication from other friends or family, and that can have some limitations. And then education, training, and awareness. Getting that right across the country will have a big impact in terms of medication safety. So some of the solutions to enhance safety center around either the person or the system. Now, a lot of the person-centric areas tend to be low effectiveness. So we need to go into system-centric areas. So automation, for example, if we look at forcing functions in some of our electronic systems, and even standardization, if we start to standardize things across different hospitals, different healthcare environments, that will help reduce medication harm. The Institute of Safe Medication Practice does have something similar. That arrow there pretty much depicts what I've just said in a hierarchical order. So I've got a few cases that I want to talk about. These are real life cases. These are from Qatar. So this first example is around the computer prescriber order entry or CPOE system. So one of the ways to reduce medication harm is actually getting the prescription right from the get-go. So if the prescriber can enter it correctly, even though we have an electronic system, you can make mistakes. So we advise to use more than 5 letters, or 5 letters at least, because that will start to eliminate some of those risks. And a good example here is we've typed in cyclo, and you can see a long list of medication and orders that the prescriber can choose. If we spend just the extra millisecond and put the S at the end, we've limited the scope for a mistake to happen, because the doctor will prescribe cyclosporine and not pick the wrong drug, which happened in this case. This was a near miss. Likewise, propofol prescribed instead of propranolol. So just a simple adjustment to your practice as a prescriber would eliminate medication harm from the beginning. This case is around the use of EpiPen. This gives you a system-wide approach. So when you start getting products from other countries, like we do here in Qatar, you've got an international market, you're getting products from different countries. You've got products in different languages, maybe different modes of administration. Getting that right can be difficult for patients, for staff to understand that as well. So we had a situation where staff and patients or parents were unable to work with this particular adrenaline pen. Quite a dangerous situation, to be fair, if they don't understand how to use the medication. So we worked with the vendor, the manufacturer. We created some training for our staff. So we did some competency training, and we created some leaflets in Arabic and in English. So again, shows that a system-wide approach to safety is the best approach. A case here around phenobarbital, where instructions were given to shake the bottle. It was a suspension. So that was given to one family member. For a few days, another family member was administering the medication, but they weren't shaking the bottle. So this patient came in, presented with some overdose symptoms, toxicity symptoms. On the back of that, we looked at some of our processes. We created some information leaflets. So again, patient education and getting the information to them in the right manner, to the right people is important. The Swiss cheese model has been alluded to quite a lot today. Just shows the importance of this model. So if we look at it from a medication management perspective, you'd hope the prescriber would be your first barrier, that they would do their checks. If something fails, it can skip past and go all the way right to the end. I've given our last barrier here as a smart infusion pump, because the example I'm going to use is around an infusion. So we had a situation where a prescriber prescribed morphine for nurse-controlled analgesia. It went past all the stages of prescribing, the dispensing checks, the administration checks. It was the last stage when the nurse entered all the data into the smart pump, that the pump alerted them that there's an error with the dose. So technology can be very important to preventing harm. Another case is around extravasation. So one of the important things in healthcare environments is that you look at your trends, that you look at your data, and that should be done at a national level. So we look at our data, what are the trends in our country? Are there prescribing errors? Are there administration errors? What are they? What can we do to mitigate and minimize those? So we found in our organization some trends around extravasation injuries. Do a lot of work around this with a multidisciplinary team, vascular management, pharmacy, physicians, nurses. We created a better classification system around it. There was better assessments, an assessment form was created in our system, and a procedure was drafted. And we looked at other organizations. I think the Children's Hospital in Philadelphia was one that we looked at. And we created our own treatment charts and policies and procedures around this, just to make things easier. So when it comes to local safety initiatives, it's important to standardize for safety, and I will touch on this particular element. We also need to break language barriers. It's important that patients and staff understand what they're being told, and obviously health literacy and awareness is very important. Public health literacy campaigns are vital. So I'll touch on standardization so that you can see how it happens on the front line. So standardization, for example, of storage labels, making it consistent across the organization. In some countries like Malaysia and Singapore, this is standardized across the country. So they have a set standards for the whole country. It's not difficult to replicate, but it makes things safer. Staff are aware, and regardless of whether you're on the patient care unit or whether you're in pharmacy, you know exactly what you've got in front of you. I mentioned the vincristine error earlier. Well, the vinca alkaloids, for example, one easy safety measure is not to have them in syringes. In fact, of the 50 plus reported errors in literature, the vinca alkaloid has been in a syringe. So One simple solution is put it into a mini bag and not to put it into a syringe. And that's what we do as an organization. We don't give intrathecal medication on the same day as IV therapy as well. So again, these little changes in your process can enable safety. You can standardize things like your dispensing labels to make information more prominent and more clear. So these were some of our IV room labels that we standardized to international standards. And you can standardize your prescription forms, your infusion forms. And you can even standardize your counseling so that the information that the pharmacist is given out, for example, is the same. Patients not missing any information. One important thing that we can standardize is between interfaces, or between inpatient and outpatient or discharge, it's having the same concentration so that the family are familiar with one strength. So when they leave the hospital, that they give the same dose. For something that you can prevent, for example, is a patient getting different concentrations of furosemide and thinking they should give 4 mils because that was what they were giving previously when they should be giving 0.4 mils because they've got a higher strength. So simple things like standardization can be very useful. And likewise, standardization of some of our medication kits, like our cold cart trays or hypothermia kits or epidural kits. Again, standardizing those for safety, color coordinating them, having some safety measures inbuilt in those can be quite useful. One last thing that I want to touch on is medication overrides with all the technology. At least 77% of our automated dispensing cabinets, the overrides occur in there. So there's room for error there if the pharmacy have not verified a prescription. So again, limiting overrides within hospital settings can be quite useful. And in terms of safety in Qatar, obviously we need to look at a system-wide safety. Pharmacovigilance should play a big part in that, and patient empowerment and getting them involved in hospital committees, for example, is quite useful. As Professor Derek mentioned earlier, the WHO strategy is quite important in this as well, and I've mentioned that in one of my last slides. So the take-home message is that a layered safety across different stages is quite important to prevent future harm, and at a local and national level, people should work together to standardize safety initiatives.
Thank you.
Thank you so much, Mr. Iqbal, for sharing your experience from Sidra and asked through different strategies in reducing medication errors. So thank you so much again, our panelists, for sharing with us different perspective how we can reduce medication or prevent medication errors and to reduce medication-related harms. So it's time for questions and answers and discussions. But first, I would like to open the floor for our panelists if they have any comments or if they have any questions for on the topic presented. If you have any comments, further comments, or shall I open the floor for questions? Okay.
Okay. So we've received some questions on WebEx. I think the first question is probably for yourself, Mr. Thabit. So you mentioned that the rise of self-care and increasing range of over-the-counter products may contribute to medication errors. So can you describe from a patient's perspective what is recommended when seeking to purchase over-the-counter products, including vitamins and supplements?
Thank you for the question. I think over-the-counter medication is really, this is becoming more and more a challenge as there is an increased over-the-counter medication. I think one of the strategies is really the public awareness. We have to ensure, and as I've touched on earlier as well, it's very important that we educate our patients to come always to their care providers with the list of their medication That includes any medication that are not prescribed or over the counter that they're using. I think that needs to be some sort of a habit. I think that really we can do that emphasis at the point of discharge for the next visit to see that if you ever make sure you always, bring that list, regardless which provider you go to. I think we need to have some sort of, we have been really doing very good job when it comes to campaigns to really, increase the public awareness about, for example, vaccination, influenza vaccine, COVID vaccine, and a lot. And I think that you've seen that increase more and more. We start seeing a lot of this information coming through the social media as well. So I think that is one way that we can increase the public awareness also about medication safety. But this particular really over the counter, I think we needed to make sure that patients bring a list of their over the counter. The second part is really the provider need to have a question always as they evaluate at the transition of care or upon discharge or upon prescribing any new medication. Providers need to be asking the patients about the medication, and one of the questions need to be is, are you taking any over the counter? And I think we needed to get to the level of Mr. Amr have touched on the literacy. I think we need to make sure that our questions are to the level of the patient, because many of us know what's over the counter medication, but you might ask this for some other patients and they won't be able to, you might not get the right answer because they don't know what's the terminology over the counter. So I think that we needed to kind of be very clear, and we need to kind of, focus and ensure that we get to the level of the patient. Thank you.
I think I agree with that. I was just going to add, there's a lot of evidence as well that the general public, patients perceive that because things can be purchased without any professional input, so you can go into Carrefour, Monoprix, or whatever, and buy medicines, that they are completely safe. And no medication is completely free of harm. And particularly when you look in this country, you can buy medication for blood pressure, for inflammatory pain. It's very important that in other countries you could not buy without prescription. So I think that's one thing that we really need to think about, is actually some sort of awareness raising that medication, just because you can buy it, is not necessarily safe. So I think that's really important. Another thing, I've done some work in herbal medicines in pregnancy. When we asked pregnant women, are you taking herbal medicines? About 3% of them said yes. When we gave them a list of medicines that were herbal medicines, 80% of them said yes. So depending how you ask that question, you will get a very different answer. So sometimes if you ask people, are you taking over-the-counter medicines, they will say no, because they don't think of them as medicines. So how you ask the question is very important in terms of the response that you're going to get.
Thank you so much. Just speaking about the prescriber knowledge of the patient's medications and educating patients to know to bring their medication list. Sometimes, and we see this in practice, patients, they don't usually are aware of their medications, and even though they forget sometimes to bring the medication list. So is there any strategy or on a national level of connecting or having like one network system of knowing patient's medication, or any other initiatives targeted for patients and family to try to address this issue?
Can I take this?
Yeah.
So, I wanted to speak about the electronic medical record. I know that the electronic medical record really touched on most of the providers. So Hamad Medical Corporation, as well as Sidra and PHCC, share the same electronic medical record. So information are available and visible to the providers as they move within the system. I don't think that the private providers are there yet, but I think that the main and the majority of the providers, you'll be able to visibly see the medication list. I think the challenge is really keeping that list updated, and I think that's where the challenge is. But we do have electronic medical record, and I think that this is really supersede many other places, and I've seen other places around the world, really when you have different providers on the same electronic medical record, that's really helped a lot with improving managing patient medication. Thank you.
Thank you. So in terms of national initiative, the Ministry of Public Health have the medication reconciliation initiative. And medication reconciliation, like transitions of care, and upon admission medication reconciliation, which is, as Mr. Tabi said, it's built in the electronic medical record that we have. There's a place for OTC or home medications to fill, and it should be always asked by the healthcare providers upon admission or transitioning to fill this. And this is a measure that's like a KPI that we submit to the Ministry of Public Health on a regular basis.
Okay, we have another question. I think, Dr. Anas, this question is directed to you. So we see and read a lot in the media regarding the opioid epidemic in the US and other countries. What strategies have been introduced locally to limit the spread of this epidemic here within Qatar?
Opioids is always a tricky area. So of course, the context in the US is totally different from Qatar. So this is in the US was mainly pushed by patient demand, and of course with the insurance system in the US, etc. Patients will go and ask for these to be prescribed legally, and they will take it from the pharmacy. But this issue, it was like a snowball, and it became like a total pandemic in the US. In Qatar, things are more controlled. There's very strict laws about controlled medications, including narcotics. They're strictly monitored by the Ministry of Public Health. They have routine visits, inspectors, auditors coming to pharmacies, community pharmacies, as well as HMC pharmacies. In HMC, for example, we have also rules and regulations and policies to control opioids and how they are prescribed and track them, etc. And every single pill is counted for. If any one pill is missed, we have to do a full investigation and the committee, and so things are, I would say, more controlled. However, it is there. We cannot say, like, for example, I'm working in the cancer hospital. Many cancer patients take opioids, and some of them get addicted on it. This is normal, and it is somehow medically acceptable. But to keep the balance between medical necessity and abuse is the important thing. So we always have awareness. Also, either in the pharmacy where we have a dedicated, or HMC pharmacies have a dedicated narcotic pharmacist who always sit with patients and try to educate them about the proper use of this drug and the need for revisiting the hospital and the physician to make sure that they still need this, because if they don't need this, they need to stop it. But yeah, I don't think we can compare the size of this issue to the US. It's totally different.
If there's any questions from the audience, please raise your hand. Yes.
Hi, so my name is Gania, and I'm a second-year student in pharmacy. This question isn't to anyone in particular, but as a future healthcare provider, the idea that I can cause harm and do errors, especially to the extent that I'm shown today, is quite terrifying. So my question to you is, what advice would you give us as future healthcare providers as to how to, one, avoid these errors, and in the case that we do these errors, how do we deal with these situations?
I should attempt to answer that question. That's a very intelligent question to ask. When it comes to safety, I think the most important thing as future pharmacists is you need to keep it at the forefront of your mind. So if you're always thinking about safety, if you're thinking about your practice, the way you work around your processes, how can you incorporate safety into those? So for example, if you're going to check a prescription, what are the steps that you're going to take to do that, and have some safety steps within it? So maybe if you are dispensing and then checking, you may separate the two processes. I might dispense something. If you're the only pharmacist, for example, you may leave it for 5 minutes and come back to it later. So sometimes small things like that within your practice will help when it comes to sort of day-to-day routine and thinking about the types of things, for example, that I've discussed that can cause harm and lead to harm. then you have to really work within the systems and processes that are around you. So if you work in a hospital or in a community pharmacy, if you've got an operating procedure that tells you to do something in a particular way, then there's a reason for that, and that's to keep yourself safe and to keep the patient safe. So working within the parameters and within your competence is another element. So sometimes you might come across something and you're not sure about it. So then you ask questions, you ask a colleague, you escalate and you find out if you're not sure. So assuming you know everything, one thing I would advise future pharmacists is not to assume you know everything. So it's one of those things where actually acknowledging that you will have limitations and taking the safety steps forward from what you do on a day-to-day basis and what your organization tells you from their procedures. I think those two things would work really well.
I was just going to add to that, whatever program you're doing, you're going to come out of this university very well educated and trained, so that will help. But also think about continued professional development, lifelong learning, so you're always learning. And the other thing to be aware of is that when things do go wrong, that you speak up and that they're reported. There's then reflection on what you've done, what the organisation has done, and how the organisation is going to respond to that. I think just to reiterate what you've said, there's not been a situation where you're working way beyond your competence. You know, what's my job? What's the expectation? And then start developing from there.
So thank you so much. I just want to I have more question related to our student questions. Since we are speaking about pharmacists, Dr. Anas, you have mentioned that the highest contributor to medication error in one of the study is the prescribing errors. So what are the role of pharmacists in reducing prescribing errors? And again, is there any initiatives here taken, or pharmacists have to do something to reduce medication errors?
Thank you. So, of course, yes. As I say, prescribing errors, even in HMC, I can say that prescribing errors make at least 80% of reported errors. Again, this is reported. It's not means this is what we know. But what reaches to the patient is less than 10%. But 90% of errors are near misses. And again, maybe 90% of these near misses are catched by pharmacy. So, of course, the pharmacy is a very important, cheese layer, defense layer for medication errors, especially prescribing errors, because administrations, we don't check it. It's nurses, sometimes check nurses or smart infusion pumps, as Mr. Abbas said, etc. So yes, of course, that's why we have lots of nuances. So we have lots of, double checking system. Now we have electronic prescribing. Electronic prescribing have embedded with it, high alert medication labels, lookalike sounded like, Tolman lettering, and many, smart things. However, still, smart solutions alone are not enough. You need to be conscious and again, know your competencies and your limits. And when you don't know, you can't ask. And that's why always we emphasize on our new pharmacists. We know that you're ambitious. We know that you'll come with lots of energy, but it's okay to ask. Don't be shy to ask. If you don't know, that's fine. But yeah, of course, they are important.
The whole dynamics of healthcare is constantly changing. So in the UK, pharmacists and other health professionals can train and register as independent prescribers, exactly the same prescribing rights as physicians. This year, undergraduates start first year pharmacy in the UK will graduate as prescribers, will be registered as prescribers. We've also got a body of research from this country around potential for pharmacists to be prescribers and take responsibility for prescribing then medicine is really doing much more with the complex diagnosis, monitoring and so on. So all that dynamics of who does what within healthcare is changing across the world and will change here as
well. From nursing and midwifery perspective, also, Derek also talked about the changes in healthcare when it comes to prescribers. So it's not only physicians, but we have clinical nurse specialists as well, pharmacists and nurse practitioners. So we're on the journey here also start having clinical nurse specialists. We know our colleagues and et cetera, they have also nurse practitioners. So with that change, nurses also and midwives also really own part of that, really to ensure about the prescribing, but also staff nurses. And I think that it's not only at the administration point, really, but also with the electronic medical record, nurses get alerted to new orders when the physicians enter that. And they own that piece of also having that knowledge that really, that, to catch those medication errors or prescribing errors at that point of time and earlier on in the process. So that is an area that we kind of try to develop in our nurses as well during education, during curriculum, as well as at their training, before they start really taking care of patients. Thank you.
Okay, so this question is from myself, and it touches on something that a number of you have mentioned in your presentation, and that's the no blame culture, and using medication errors as a point to learn from, to reflect on, and to improve practice. So I guess my question is, where are we with that culture here in Qatar, and how can we integrate it more within our healthcare system?
I just would like to add to Dr. Zak's comment is about incidence reporting and how we can improve self reporting. Like when we have a practitioner has an error, I know there is an agency, they have the incidence report or the OPA, so we can improve the self also reporting.
Okay, so I think this applies to all healthcare professionals. I would say that self-reporting is still very limited. It's there, but it's very, very limited. Although we always say that the best one to report the error is the one who committed it. But again, this brings us to the no blame culture. Maybe yesterday you heard there was one pharmacist who was sentenced. But again, we don't know the details. There is some recklessness maybe, but the idea is like this no blame culture is always there. We always promote it. We always try to raise awareness about it, that we have in Qatar and in HMC, I'm sure in Sidra, we have no blame culture. But how much do we really have that? I don't think we reached there yet. We're improving. We have many reports. Some people before they were, when I report like a physician who I work with every day, I don't report the physician, I report the error. And the physician was the one they were coming to the pharmacy, literally coming to the pharmacy and shouting and blaming the pharmacist. We thought we were friends. I thought that you were my friend, You stabbed me in the back. This has literally happened in HMC before. That was like more than 10 years ago. But things like improved. We have anonymity. We have, no shame. Everyone commit. So we try to promote this. I think things are improving, but slowly. Some departments are better than others. You can feel that. Some hospitals are better than others. So things are still need lots of efforts. But maybe I would like to hear from nurses as well, because we always have the feel that nurses sometimes have this. I don't know. This is what we feel. But you can. Like nurses like to keep it, internal, maybe investigate it internally. They don't like to report much, and that's why, like in the UK, you feel the number one error is administration errors. While here, we have rare number of administration errors reported in our OVA system.
Thank you, Dr. Anas. I wanted to say that reporting continue to be a challenge, and I think that we are actually we are privileged at HMC to have the patient safety culture survey that's led by the corporate quality department that is really administered to all HMC. This is a survey by the Agency on Healthcare Research and Quality. And really one of the areas that continue to be a challenge, we have seen some improvement, is really the no blame culture. And I would tell you that this is not specific to one area, but it's really across. You've seen this, I've seen this in the US. I think this is a challenge. The nurses I've worked with in North America really are afraid of consequences. So I would say it is a journey for every country. We have seen, as Dr. Anas, we have seen an improvement. I've been with HMC for 7 years, so I probably didn't witness some of the challenges. But since the time we have started, we have seen the safety culture, and we've seen the changes. Dr. Mozart is leading on some of the conferences, and now the risk management conference, which is upcoming at the end of the month. This is the fourth conference. And actually, when you see highlights on some of those events, a lot of the highlights is really on the safety culture. So I think it is out there. I think everyone is trying to bring it forward. But we know that any organization, in order to get where they want it to be, it is a journey, and it really takes a lot. I think that we need to invest in our healthcare, in the future healthcare providers. I think we need to ensure that we really educate them about the importance of reporting and the no consequences. I do have a privilege to work with colleagues also on reviewing many of the adverse events on a committee and all of that. And I've seen some great examples of a no blame really, that really helps to kind of focus on systems. I think the challenge is the awareness really. And I think that awareness needs to be, there is one video that I have seen that probably I would never forget really on YouTube. It's available on YouTube about one of the nurses that really was administering insulin. And I think that this is a very famous story for a nurse in North America where there were an issue, and I think a patient got unconscious and the nurse got fired. And then you really see about that event have happened with another nurse a week later. And the challenge is really, there comes from us really kind of trying to kind of, blaming individuals. When you blame, then you go wrong because there is a lot of system. I think we need to invest also in our healthcare providers and the future ones also to help them understand that there are system of processes and there's a likelihood for error to happen at multiple. And I think that if we focus on the individual, we'll go wrong. It is a journey, the safety culture, and we needed to continue to kind of, increase the awareness about the reporting. Thank you.
I'm just going to add some of the research we published from HMC a few years ago on reporting showed that some of the biggest deterrents to reporting were the emotions around reporting, but the beliefs of the consequences. And these are really difficult things to change. It's also interesting in a way that the literature's really moving away from the term no blame culture to a fair blame culture. That sometimes blame is appropriate. So it's actually the blame is fair rather than just being completely,
So thank you all for this nice panel discussion. Really happy to be there. My name is Shamos Mohammed, Senior Specialist Patient Safety Minister of Public Health. We thank Qatar University College of Pharmacy for organizing such a nice discussion. I have one question for Dr. Derek, but before I come to this question, I want to comment on the just culture or the reporting. I think we need to many policies, regulations to be in place in order to help not just awareness, to support building this kind of culture. We need to put in place law to protect our health providers. In the same time, incentives to encourage our staff to report. Also, many things need to be put in place, plus awareness. I think in the future, near future, in Qatar, we are planning to have a national reporting system where not only is available in organization level, but right now we are working to have that in national level. And in one of the phases of this project, we are working that we open a platform for patients also to report. So I hope this will work as a plan. My question for Dr. Derek is about registered prescriber, you say. What is take to for pharmacists just graduate as pharmacists to become a registered prescriber from certificates or training. This number one. And also, do you think that it's you Qatar here now, or when that can happen? And it's really benefit in UK. So I know it's long time since 2011 or more. So do you see this beneficial?
In the UK, it became legal in 2003, not just for pharmacists, but for some specific nursing groups, dietitians, radiographers. They do additional training. So at the moment, they do really a short training course for pharmacists. It's not really around therapeutics because they've done all of that. It's more around prescribing governance, consultation skills, ways of working. So they're a university-based course, and then a period of working in practice with what's termed a designated medical practitioner, although now pharmacists can take that role as well, really to sign them off as being competent. And then there's an annotation in the Register of Pharmacists in the UK to say that they are prescribers. They then work within their competence. That's now going into the undergraduate programme in pharmacy, so that all pharmacy students that start this year, as they graduate, will be registered prescribers. In this country, we've published a number of studies. I had a PhD student, his name Jabara, who's one of the first real years of graduates at Qatar University, did her PhD in Scotland, but collected the data here, really from key stakeholders to look at their views, their opinions, so stakeholders in medicine, pharmacy, nursing, risk, patient safety, members of the public, and so on, around a framework to establish that. That's being developed further and is now a proposal. I think it's still sitting with the ministry to look at that in the licensing committee. If that's approved, it then translates to a university programme, a short graduate programme, to then start training people around that health and license. So this country is probably further on than other countries in the region, but other countries in the region are looking at it as well. So I think there's a window of opportunity for Qatar to really get in first where it should be, but I don't think that window of opportunity will be there long. But there is a lot of evidence. I led a big research group in the UK around pharmacist prescribing, published 50 studies, including a big Cochrane review on the effectiveness and safety of non-medical prescribing, which covered pharmacists and nurse prescribers, showing that its effectiveness is at least as effective and as safe as doctor prescribing. So we've got a range of evidence there.
Thank you very much, everybody. I think that's all we have time for in terms of your questions. I know there may have been a lot more questions. We're happy to take your questions by email and put them forward to the speakers. If you would like to receive the slides for today, you can email the CPD department here at Qatar University Health. I'd like to take this final opportunity again to thank our speakers, to thank Dr. Faras Al-Ali for coming up with this initiative and working with the ministry on this collaborative project. Thank you all again for attending. If you would like to receive the certificate for today's event, you can scan the QR code that appears on your screen now. The link is also available. You can complete the evaluation and the certificate will be sent automatically to your registered email accounts. Thank you very much, everybody, and look forward to welcoming you back to our CPD events in the near future. Thank you very much.
Thank you.